Okay, so thank you again to the day team, and it's been a wonderful conference this morning. I've been trying to log in and log out, but been attending right from the inauguration and its deliberations on some very important topics, and especially I really like that it's a day dedicated to diabetes educators, and really kudos to the day team for doing such fantastic work. Big thank you to Cheryl for introducing me to this conference and calling me here. And without further ado, let me just move to the topic. Before I also go to the main topic, I'd just like to say a little bit about translational research. And what I really do is I'm representing my organization, which is Dr. Mohan's Diabetes Specialty Center, which is a tertiary care diabetes center in Chennai, and we have around 48 branches all over India. And I'm now part of research full time. I'm no longer really counseling patients one-to-one, but we do it in the field as a public health angle. And so I'm representing the Madras Diabetes Research Foundation here. And having said that, what I do in translation research is basically what is translation research is, from the bench to the bedside to the public, right? So it's from the bench bedside to the community. And, my last 2 decades of working as a nutritionist and then further on as a public health specialist with epidemiology and translational health thrown in, I've been lucky that I've worked in all 3 angles. So I've worked in clinical trials. I have worked in the center, in the tertiary care center, and in a multi-specialty hospital previously in Mumbai and in Bangalore, and where I've worked with patients one-to-one. And now I've moved full-time to public health because I really believe a lot in prevention and the power of prevention. And I think that's the need now with diabetes too. So moving on. No conflict of interest, and just a little bit on epidemiology as well as the numbers. I'm sure in the panel sessions the doctors will be speaking a lot about the numbers, and we have had a lot of talk on diet since morning. But just to get back to what are these numbers of diabetes and what they look like. So we currently have around 77 million in India, and the projections for 2030 is 101 million people. But this is from the IDF 9th edition, which has happened last year. And these are projections which are done every 2 years. But please remember, these projections were done pre-COVID time. And if we all working in this field of diabetes, we know how COVID is coming up as one of the biggest risk factors, and also playing a very big role in mortality with especially diabetes is coming up as a big comorbidity for COVID. And there seems to be a lot of mechanisms and lots of theories at work here. But one thing is for sure, that these numbers are going to be very, very different when we do the projections again, because there has been a lot of new cases with the upcoming research. Due to COVID, there seems to be a lot of newly diagnosed cases of diabetes too. We're just hoping, and we have to do much more studies to know that it's something that can be reversed. But having said that, diabetes is coming out as one of the biggest killers in COVID cases too, and that also seem to be susceptible to infections. So with all this focus with COVID and diabetes, one of the other things that I think is getting a little sidelined also is pre-diabetes. So if you have 77 million with diabetes, you almost have 88 million with pre-diabetes. And these are the people who are at high risk to develop diabetes. So we have to be targeting these people also to some kind of intervention and giving them some kind of education, so that we do not see these increasing number of cases in future. And in that, along with diet, I think physical activity plays a very, very important role. And why? So there are a lot of studies on physical activity too, but this is one of the largest studies, epidemiological studies on diabetes per se, being coordinated by a center by my colleagues, Dr. Anjana, Dr. Pradeepa, Dr. Deepa, and Dr. Sudha Vasudevan, who just spoke a while back. They're all part of this huge epidemiological study being covering almost every state of India. And there's a lot of publications. You can look up ICMR INDAP. There's a lot of data from this emerging. But I'm specifically going to focus on the physical activity and inactivity patterns that we got out from this. And what this really tells you is, so what this really tells you is India per se and Indians per se, we are basically a bunch of lazy people, okay? We do no recreational activity. So we stand out in distinction across states. If you see, there is almost 90% and above. Forget this, we are merit holders, because none of us really do much of recreational activity. We don't believe in doing any kind of exercise per se. And why, maybe we could say what's going wrong. Well, this is modern India for you. A picture speaks 1,000 words. And well, I guess we are all waiting to go back to these crowds and, where you have so much vehicles with all this pandemic ongoing. But this is the fact. So we could say the COVID is just it's just a standard error from the mean. But what is actually India is this, right? And modern India is this. How many of us have seen people having treadmills at home where they hang clothes, or this is just another extent where a person decided to use it as a bed. But having said that, this is what it is. Basically, we are all a lot of sedentary people, a bunch of sedentary people who don't really involve ourselves in any time of leisure time physical activity. What are the changes? The epidemiological, nutritional, physical activity, all kind of transitional changes that has happened between then and now. Believe me, this is even happening in the rural areas. It's not just the urban areas where we are saying that this physical activity is less. The belief was always that. But if you go to see, now we're in the rural. So how many people are running behind the bullock carts? You have tractors come up everywhere. How many people are really plowing and doing stuff? You have a lot of mechanizations that's come up even in the rural area, leave alone the urban. And so the people who are walking and who are cycling are now moved to obviously the motorcycles and the cars. People who are taking pots of water, they have tankers. People have tankers at home, even in there. You might have water paucity even in a city like Mumbai, but still people have developed different mechanisms through which this kind of physical activity that they used to do part of their daily life has now kind of just vanished. And of course, this is one of my favorite pictures with regards to TV, because, a few years back, that is how our TV was. We used to have fat TVs and we were thin ourselves. And nowadays, all of us have flat screens. And obviously, our TVs are now, become thin, whereas we have become fat sitting on the couch and watching it. So this is another picture which somebody had sent me actually on WhatsApp. And I find that very, very interesting kind of a picture, because if you see the grandma's gym, somebody called it and sent it to me. And it's so interesting because you have for chutney, you had your, the slab for chutney, you had something else for kusawing, basically making, grinding the rice, the dals. Then you had your chilies being broken with those hand pound things. So this was basically our gym. And that's what is weight training, isn't it? Now what we're doing is we go to the gym and we're carrying weights and we spend thousands of money for it. And that's what we're doing, because now our kitchens are classier, it's cleaner, and it's basically all mechanized. So what is the connection to diabetes? So prevalence of diabetes according to physical activity levels, as I said, again, this is in data that I've borrowed. And just to show very active, and inactive, it's a very classic differentiation, right? So the orange bars are people who are inactive, and look at their diabetes prevalence. It's 11% in urban, 6% in rural, and overall it's 7% versus somebody who's doing activity, which would be around 4% or so. And remember, this is, irrespective of age and gender and everything. The more you start classifying it, and we do have data on all this by sex, by age groups, it's a very, very classic differentiation between people who are active and inactive and their risk for diabetes, because we have many other studies which also have measured this. So what is the role of exercise in diabetes, right? You have it for prevention, you do have it for control, and you do have it for managing the complications. So I will talk about control and managing complications first, and in the end, I will speak a bit about prevention, because we're speaking mainly from a patient perspective right now. So what are the benefits of exercise? The previous speaker just touched on this on a few, on the last two slides, but just to go into detail, yes, weight loss is all accepted. We do exercise, we expect weight loss, but it's not a miracle. It's not going to be that way, because one of the classic sayings that I like to say as a nutritionist and a public health specialist is you can never outrun a bad diet, right? So whatever exercise you do, your diet has to be in place. And by diet, I just mean healthy eating. I'm not saying anything outlandish here. So what are these benefits of exercise? Even though weight loss there, weight maintenance there, you have several benefits of exercise. And that it's reducing your total cholesterol, decreasing your LDL cholesterol, increasing HDL, decreasing triglyceride. Remember, if sugars go up, triglycerides tend to go up. So if that comes down, this will also come down. But HDL cholesterol, we, again, as a South Asian specific, we have a lot of studies to show we are sarcopenic. We also have potentially, low HDL compared to Caucasians or other populations. And there are also studies to show exercise has even done better benefits than statins in some cases, where by doing regular routine physical, the recommended exercise notions, people have increased their HDL, which is, what more do you want? You're not spending anything much, but you can increase something like the good cholesterol. I think that's should be a high point. for benefits of exercise. Of course, it decreases blood pressure, decreases your weight, decreases body fat, and of course, increases muscle mass, which is very important for sarcopenic Indians. And of course, alleviates stress, which means it reduces the stress. So what are these components of exercise? You do have the immediate effects, which is the aerobic, which is what we all do, and the long-term effects, which is the resistance training. Okay, so I'll speak a bit on both of them. So this is what is the recommendation. That is 150 minutes per week of moderate intensity aerobic physical activity. And in the absence of contraindications, you do resistance training 3 times a week. Even twice a week is quite good. And three times is depending on your time and your liking for it. But resistance training is very, very, very important. Just doing a walking or any kind of aerobic activity alone will not help, and it will not give you those other benefits of exercise, which resistance training, along with resistance training, you will get. So leisure time activities, there are several. So cycling, jogging, dancing, riding, playing a sport, swimming, cricket, whatever, just take up something. The point of the matter is do something. Just move your body for those 150 minutes activity, whatever you like. They're just, the slide is meant to just show that there is a variety out there. So when I talk about effects of exercise on type 2 diabetes, I'm not talking about those effects that are actually there, but when you do exercise, what happens to those blood sugars? So when you look at type 2 diabetes, actually there are no big precautions that a person needs to really take. Even, if you are taking tablets, you would be having it before breakfast. If you're going to get up in the morning and go for an exercise, you don't really need one protein shake or some high carbohydrate dense food, like as though, it's something very, very, you're going to fall off low sugar. It doesn't really happen. Again, it's patient perspective. You have to look at what a patient is saying. But then I've also seen of late, the norm is to just prescribe a high protein powder or a supplement. Very commonly, anyone who's doing exercise, like exercise, which is 30 minutes of walking or 1 hour of walking, doesn't really need this. This is just additional food that you're giving to people, which is not really required. You fit it inside their diet regime for the day, that's a different thing. But if you're going to add this as something additional just to make that patient feel good, it doesn't really work. You're harming the patient more than even that exercise they've done will just be a waste, because what they have gained from this protein powder and all that, you will just be giving them additional calories. So please, the prescription, when I'll come back to the topic there, is here it's very, very important that it's one size does not fit all. Protein supplements, protein powders, what happens is you need them more for somebody who's active sports, very, very intense sports, a marathon runner, or somebody who's a regular sports person. He plays hockey, he plays tennis, and he's like a sportsman. Yes, their needs are very, very different. But here I'm talking about a general patient who's normal, who goes to work, comes back, and does some kind of leisure time physical activity. You need to give them anything additional for their exercise. They come back, eat their normal breakfast. If they're going in the evening, they would have had a tea or something anyway. They come back, they eat their dinner after a while. That's more than enough. In the long run, especially beneficial reduction in blood glucose levels due to improved insulin sensitivity. That's what the previous speaker also spoke. Coming to type 1 diabetes, of course, you have to be a little more careful. But having said that, that does not mean they do not exercise. Okay, you have fantastic equipments nowadays. You have CGMS, you have AGP, you have the pumps, and even if they're on a syringe or if they're on a pen, there are lots of ways to monitor your blood sugar levels before and after. I'm not going to go into details. We just had a session on technology also. But you have to keep in mind, from a patient perspective, is the type and intensity of exercise. The carbohydrate intake during and after for them is very, very important. And insulin levels in blood during exercise. Before I move on, I'll just give you a small example here, because I remember a talk I attended of Wasim Akram at IDF in Vancouver. And he told a very interesting thing. I mean, for everyone, people who don't know, maybe he's a type 1 diabetic, and he's one of the biggest diabetes ambassadors, Wasim Akram. And he actually mentioned once that, in that talk, and it really struck something home when we say that one prescription does not, one size does not fit all. He said his physician told him, because, he's an awesome bowler and he's one of the highest ranked fast bowlers with, speed that we can't even imagine. So when you're bowling in that kind of a speed, you need extreme power, you need a lot of energy, you need a lot of endurance too. So his doctor used to tell him is, before you bowl an over, eat something high on carbs and then go for your over. But as he started doing that, he realized that the high carbohydrate actually made him more lethargic. So what he devised himself is he started experimenting, and he was keeping an eye on his insulin and his sugar levels. He used to finish the over and immediately go back to the dressing room and eat something which is a combination of carb and protein. He realized that helped him sustain, and that actually helped his endurance. So when we talk about one size fits all, it is totally with the patient in the center. You have to work around this. And this, if a patient is telling you, we as a physician, we or as a educator might think, no, you'll go into a hypo, so you should be stuffing yourself with carb. But well, that's his game. That game is his life. So we can't really push him to do that, because then he's reducing his speed. Then there's nothing unique about Wasim Akram, right? So he had to figure that out himself, and then he discussed with his team, and then they changed his plan accordingly. So that's how prescriptions change when you have the patient in between. So as I already started, one size definitely does not fit all. And what helps in exercise, just like one diet does not fit all, it's the same for exercise, is you use the FIT principle. So you have to keep in mind frequency, intensity, type, and time. So frequency, at least 5 days a week, okay? If not 4 days. As I said, remember the recommendation is 150 minutes per week. So it can be 30 minutes per day or 45 minutes, thrice a week. But if you want to reach a moderate intensity, that's for normal recommendation. But if you're looking like something like 10,000 steps, which is now added as a perfect way, to prevent disease or improve that intensity, a 1 hour walk has to be 5 to 6 kilometers per hour. Okay. So when you speak to your patient about intensity, please figure if they know what you mean by 1 hour. They'll be just gallivanting happily with some friends and walking around and saying, yeah, doctor, I took the walk for 1 hour. But what speed, how much time, what did they really do? We don't know. So if you give them a target, which is very specific, and say, look, you have to cover 5 to 6 kilometers an hour. It can be 2 to 3 kilometers, half an hour. But what you do is you reach there. That is, you don't, for somebody, remember 90% of us don't exercise. So you can't start telling them to do 5 to 6 kilometers an hour. They're going to collapse, not because of hypo or anything for a diet, but for any normal person, they're going to collapse more because they're not used to it. They'll be tired, they'll be dead, they might be just breathless with that kind of walking. So we start slowly, we grade it. But please remember, the FIT principle has to be explained to the patient, and that's what you design to them. You actually tell them what should be their frequency for the first week, what should be for the first 2 weeks, then how you grade it to the next 2 weeks. That these are things that needs to be listed by an educator. The type, as I said, please remember a combination of aerobic and resistance. It's very easy to tell a patient, go take a walk. I don't think they need us to tell them that. That's the most obvious exercise. But there are many others. If you, just like how you do a diet review and you ask what the patient really likes and then try to include that in the diet. Similarly for exercise, you never know, a patient would have been a hockey player or loves playing badminton or loves running or loves cycling. Those people have to be called back and told, maybe what is a sport that you really like, and then add that to it. So important points to note here is exercise regimes are highly individualized. Graded exercise programs are the norm. As I said, grade them. Don't start them at a peak. Start them slowly, steadily, and increase it. Warm up and stretches and cool down are extremely essential. We cannot have somebody, we are like these old chairs, an old chair, if you open it, it'll make all kinds of noises, right? They crack. So that similarly, we are not a well-oiled machinery if you're not doing exercise. So you please see that you're ensuring that they have warm-up, stretches, and cool down as part of this exercise pattern. Loose fitting clothing, proper footwear, very, very important. Sip on water. Have water, but please sip on water. People tend to gulp, and then after that, you start having abdominal cramps. So they need to sip on water while exercising. Extremes of temperature are best avoided. For type 1, again, the same checks, that is, please check, half a carbohydrate snack before, after. As I said, these are standardized, but you have to individualize it to a patient. And blood sugars, if they are high, of course, you have to ask them to, get it down a bit before they go for the walk. And it's very important for them to check their sugars before and after. So with complications of diabetes, so for proliferative retinopathy, it's better to have a little bit low impact. So swimming or walking, too much of running might not be recommended. Similarly, strenuous activity like jogging, weightlifting, Valsalva maneuver is basically, closing your nose and trying to force breathe through your mouth. And this seems to be one of the common ways in, that they put it as part of yoga and do it. So we have to be aware of these different types of activities. It's very, very important. Nephropathy, low to moderate intensity, high intensity has to be discouraged. If you have peripheral neuropathy, then swimming, bicycling, rowing, they're softer. Your base should be very, very important. Treadmill, jogging and all, you don't know what kind of surface, so it's better avoided. Autonomic neuropathy, again, exercise in extremes of temperature should be avoided. Just a little bit on prevention. This is one of our big studies that we did, and it was a grant funded by IDF, and it's based on the DPP. We adapted the DPP lesson plans to an Indian setting and gave 24 lifestyle classes to them. And we found out that we could reduce 32% of diabetes by just lifestyle intervention. And when I say lifestyle intervention, it was diet, exercise. We spoke a lot on behavior change, and we made them do exercise. And these were the classes that we had. So we had people from the community coming to us and we were teaching them. And if you see, there's a fitness consultant teaching them. And that's why I put this up, because I would like to also share is an educator, just like we are very experienced, we can give a know-how about exercise. The one imparting that exercise has to be somebody who's specialized in it too. So having a fitness trainer, a physiotherapist, maybe trained a little bit on fitness, who knows the know-how of the muscle groups and what suits a patient, is very important to be part of your diabetes care team. Because just like we might be experts on insulin initiation, just like along with the nurse or diet, we need somebody who's an expert on specific exercises. Just before I end, the last two slides is a bit on the barriers of change. So from the same study, we figured out that exercise patterns and behavior are not the same for everybody. And yes, like it's normal for people across ages, like, something a teen does will be very different from a young adult to somebody in their productive age of 30 to 40 to 50 and somebody who's older. But there's a big barrier among women and male, and people don't tend to address this gender bias all the time. So though the men are the breadwinners of the family, and obviously health is the biggest priority for them in every family. It's not just, I would say it's not just an Indian thing, it's across the board. But we need to understand what are the barriers a woman faces. It's not that they don't like to exercise. It's not that they don't want to be healthy. One is they're not given that much time or given that much importance to, tell them, look, you can also take time out to exercise. And look at their barriers. These are barriers the women have placed to us. And, embarrassed to exercise in a pub and in a cultural setting like India, it's very, very common for women to, feel that people are looking at me, kind of clothes I'm wearing. All this matters to the woman. So what we did is we found out features of an ideal physical activity intervention for women and girls. And this was done by a lot of qualitative work. So as educators, I always push that I think it's very important, along with quantitative knowledge, please find out barriers and implementation challenges and things like that the patient faces. Only then we can actually, whether it's diet or whether it's exercise, we can tailor it to that patient more specifically. So we found out that for women, we need something that's innovative, that's interesting, sustainable, less time, very, very important, socially acceptable, so that nobody says, oh, look what kind of clothes you're wearing, why you need to exercise and things like that. Done at home, and should be fun, because that's what sustains their interest. And that's how, ladies and gentlemen, we came up with an intervention called Thunder, which mixes HIIT, a high intensity interval training routine, with dance. And this is something we have launched, and we're waiting for COVID pandemic to kind of, where we can go back to the schools, and we're soon going to get it for women as well as people with diabetes. I would just give a small push on HIIT, because not many people talk about high intensity interval training. It actually addresses all your flexibility, aerobic and strength components. And it's, people, what is HIIT is basically a high intensity of running or jogging or dancing, and follow it up with a little bit of low intensity. That's what is required. And this is a very short time. It can be done for 15 to 20 minutes, and that's it. You can break this into portions of doing it in the morning and afternoon, and that's how it becomes very convenient for people to do it too. And of course, the benefits are just like any other exercise. In fact, it's even more, because it kind of has a very good cardiopulmonary fitness into it, and along with strength and aerobic training. When we did this research, we finally found that there was one study, and that was a randomized control trial by Dr. Palniappan's group, where they actually tried doing a dance-based exercise intervention for women, and they found that it actually even reduced their HbA1c. So we were thrilled, and we had this concept much before that, and we, a lot of people who attended IDA would have witnessed this too last year. But we seen that, I'm glad to see that people are coming up with these kind of interventions. Ours is not purely dance; it's with HIIT, so there is is a little bit of things that we have to look into, and it's still under development. But what the point of the matter is, people can do anything in the form of exercise as long as they're moving. That's most important. I just like to end with the Fit India movement and reminding all educators and everybody who's watching this is that our Honorable Prime Minister had actually mooted something called the Fit India movement last August. And it's basically to encourage people to inculcate physical activity and sports in their daily life. So you, as educators, I think we are not in any position to recommend others exercise if we don't do it ourselves, right? So we need to be aware and do see that we are moving first for an hour and see what are the problems, what are the issues we face, so that when a patient comes and tells us their issues, we're able to understand and kind of navigate it through, and see that we have everyone in the same plateau, on the same plane, and we can try and make India a much fitter nation, if not anything else. Thank you. And I guess I would just like to end, if we can do that, we would also ensure that, the exercise prescription is individualized, and it's definitely that one size does not fit all. Thank you.